So we're starting?
Yes, I think it's just fine.
So hello everybody, we are going to start in another 30 seconds. Good evening everybody and welcome to this webinar on inflammatory bowel disease emerging nations consortium. Now what we found a few years back was that not only the incidence of inflammatory bowel disease increasing over the last few years in some of the developing countries, but also we found that many of the so-called common developing countries, we name them as emerging nations, have similar pattern of IBD and similar impact in terms of rise of IBD. So Dr. Rupa at our institute got together group of these emerging nations with the help of some international consultants and then put together a conference some years back. The product of this conference was a very interesting paper that was published recently showing the trends of IBD in these nations and the impact of how it's increasing. This has become extremely important because I think we are actually about 50 years behind what happened in the developed nations, and this may actually give us a clue about what's going to be the etiopathogenesis of this disease. We have formalized this today. Over 20 nations have joined this IBD Enc Forum, and this program is part of starting this forum. We have a variety of things today. First of all, we'll have actually the inauguration of the webinar, the website which we started for this, and then followed by 3 very interesting lectures by very eminent people. So this webinar is going to be moderated by Dr. Rupa Banerjee, who is the director of the inflammatory bowel disease at the AAG, and Professor Ida Hilmi, who is a professor of gastroenterology at University of Malaya in Kuala Lumpur. So we'll first start with Rupa.
Thank you, Dr. Reddy. It is indeed a time way back to 2016 when key opinion leaders, we all got together and found that IBD was increasing in this part of the world. And we thought that we faced similar challenges in diagnosis, in management. In fact, our disease appeared to be different. We were facing similar challenges. Seeing this, we initially started a small group. We called it the SAARC nations. Gradually it became Southeast Asia, extended on to Middle East, and now we have a lot of African nations also joining us in this endeavor. We've had workshops, we've had meetings, we've collected data of more than 10,000 patients now, and we find that indeed our disease is showing different trends which is different from the Western world. We've had great mentors with us. We have Professor Simon Travis, we have Professor Sue Ng, a close friend. We have Iris Dotan from Israel, again another good friend. Professor Ailsa Hart, Professor Michael Cam. All of these mentors have helped us guide and together form what we wanted. We also realized that we needed a platform to work together. I'll just show a short video of IBD Enc as it stands today. Could I have the video, please? So thank you so much. But after this, we realized we needed a platform where we could discuss our difficult cases, where we could highlight the needs of the region, highlight our patients' needs. And for that purpose, an interactive web platform was needed. For the purpose, we are today proud to say that as a group, we are ready to launch the global first ever interactive IBD platform spanning more than 20 nations across the South, South Asia, Southeast Asia, Middle East and Africa. And it would not have been possible without the help of one person, Dr. Azad Moopen. I hand over to Dr. Reddy for the official launch of the website.
To launch this website, we are fortunate to have with us Dr. Azad Moopen. Dr. Azad Moopen actually started with a single doctor clinic in Dubai in 1987. Over 33 years, he's built the largest medical conglomerate, a global conglomerate of 377 facilities across 8 countries. His huge number of beds all over Middle East, in India. He's not only a great doctor but a great philanthropist. In fact, he has committed 20% of his total income for philanthropy. He's been a recipient of the Padma Shri from Government of India, a recipient of Parvasi Bharatiya Sanman. He received many awards, Arab Health Award for Outstanding Contribution from Middle East, the Best Doctor Award from Government of Kerala. He's also got the Kerala Ratna Award, the Dubai Service of Excellence Award by Government of Dubai, many of these awards, and he's of course an FRCP also. Now, Azad Moopen has been very close to us for several years. He is in fact about few years back, some of you have been to our IBD conference will remember the outstanding talk he gave of his personal journey through this difficult disease. In fact, he received a standing ovation from over 1,000 IBD specialists who were present at that site. This website is because of the generosity of Dr. Azad Moopen, and we welcome him today to launch this website. Azad, thank you very much for being with us this evening. I think you have to unmute your mic.
Yeah, I think.
You have to unmute. Your mic is muted, Azad.
Yeah, I have unmuted.
Yeah, now it's, yeah, okay, now, please go ahead.
So thank you very much. Thanks a lot for that glowing introduction, Dr. Reddy and Dr. Rupa. And I am extremely happy to be here facing all the gastroenterologists, and greetings to all the delegates who have joined us. It's my great privilege to be here this evening with you all for this global interactive IBD platform launch of the Emerging Nations Consortium. I know that this is being started and driven by Dr. Rupa Banerjee and others under the guidance of stalwarts like Professor Simon Travis and Dr. Nageshwar Reddy. And this is also a special day. Today is actually the 25th year of the Asian Institute of Gastroenterology coming into existence. So it's a very special day, not today, this month. And this has been something which was reserved for that. That's what Dr. Reddy and Dr. Ruba told me. So I thought that I have to be there. I have been to the new AIG hospital, which, like anything that Dr. Reddy does, who has a penchant for great things, to do great things. He has created a mammoth and sophisticated hospital. And not only that, more importantly, it is not the size, it is actually what is being done there. I had the privilege of visiting the research center and innovation center, which I should say is one among the best, not only in the area of gastroenterology, but overall when you look at the overall facilities there, it is fantastic. I appreciate AIG for being in the forefront of gastroenterology and becoming a synonym for this in the Southeast Asia as well as in the whole of Asia for that matter. The inauguration of the IBD Enc, which we are doing now, as has been told already by Dr. Ruba, I don't want to go further into that and bore you. And we know that there is a difference in the disease pattern. I myself, my journey itself tells that. 12 years back, I had to go all the way to America to even diagnose that I have IBD. Now that whole situation has changed. So I was diagnosed with Crohn's, and in the last 12 years, all that could be done in the Western countries are being done now in our country or in other countries in the Middle East, as well as in the other, definitely other Southeast Asian countries, and even in the African countries. I'm really happy that the understanding of the disease has completely changed, and our gastroenterologists, even our physicians and GPs, are now aware of IBD as an entity. Earlier it was not like that. When I studied and all, it was not at all there, and even when I became a patient 15 years back, it was not there. Extremely happy, and this is going to completely change if there is a common platform where this can be, all the patient data can be uploaded and can be interactive. It is going to be a game changer in the overall research and going forward. We know that what happened in peptic ulcer and all. On fine morning, somebody found out Helicobacter, and there it disappears, peptic ulcer as an entity, which as students, that was our greatest, clinical learning at that point of time. I'm sure there will be lot of things coming out of the enterobiomes and related areas as we go forward. And we have to hear from the experts about that. My journey, I have become a minor celebrity, not as a doctor, definitely, but as a patient. And I have been invited into many places to talk about my journey. So I have got this privilege of having a Crohn's, which is not usually seen in most people, and it's very rare. It's a duodenal Crohn's, and that is why I have to tell a story. I have a story, and I can tell it in different places. And I have been extremely well received, and thank you all for that. And many of the people who are here, who will be listening to this, are my doctors as well, actually, including Professor Simon, as well as Dr. Reddy, Dr. Rupa. There are many others. I am not naming everybody. So I am more like a patient in front of you, not like a doctor or a colleague. And I am extremely thankful to you for giving me this opportunity. Finally, one request that I have from the point of view of a patient and from the point of view of many of you as the doctors who are in the third world countries, I think that there is a requirement for us to have a biologic which is affordable to the common man. This is something people like us may not find it a huge issue to afford, but most patients who are diagnosed, unfortunately, who require biologic, find it extremely difficult. So my request to everyone is that we should prod and prompt and tell the pharma companies that there is a requirement for this to come into existence. I know that newer and newer forms are coming, but it will be taking many years, but at least those which are out of patent, I hope that this will be available in our countries for serving the patients who require that. Once again, thank you very much. And with Dr. Reddy, I am extremely pleased and proud to do this honor of inaugurating this platform.
Thank you, Azad. Thank you. Very well said. And thank you for inaugurating this web-based platform. We'll ask Dr. Partha Apal, who works as a consultant in the IBD clinic, to tell us about this, to take us through this. Partha?
Very good evening to all the members of IBD Enc, and good afternoon to our members in Middle East as well as in Africa. It gives me immense pleasure to launch this website, our IBD Enc website, which is about launch now. The journey started in November 2018 when we first discussed about the online web platform, and then after that we met in December 2019 in APDW Kolkata when we discussed our first paper, and right now today we are going to launch the website.
Yeah. Okay, so we'll launch it now officially. Okay, yeah, you can go ahead.
Yes, so this is my pleasure to launch, introduce you to this IBD Enc website, which has several interfaces such as a personalized IBD registry, IBD journal scan, and a discussion, case discussion forum where we can discuss difficult cases as well as latest IBD news and patient education programs also. Can I have the slides, please?
So this is a platform which has been very well thought of, and as the slides are coming on, just to let you know that it took us some time to develop this platform, and it's got everything for the patients, for the doctors, for researchers and so on. Very comprehensive platform. You can have the slides, so yeah.
Yes. So this is the front page, the home page of our website, which has 9 tabs initially. So the main part of the website is
Next slide.
So the first part of our website is personalized IBD registry for our members, which is password protected virtual registry for which is only accessible to the members. And second section is difficult case discussion forum, where the members can access and discuss their difficult cases they face in their day-to-day practice. Then IBD journal scans, in which we select top articles from high impact journals every month which is relevant to our practice in this area, and latest IBD news like latest conferences, newer drugs launch, then newer devices and newer discovery. We will regularly update that. And then for patient education, we will regularly post videos and contents on in this, and in the future we plan to develop a patient support group and patient discussion platform for this also, which will be helpful. Can we have the next slide? So to join the personalized IBD registry, the steps are to create an account. After the admin approval, you will get a you will set a password. Then you are all set to create your own registry. You enter the patient details. Next slide. Then these are the tabs that we have created for our initial demographic study, in which we studied the demographics, disease phenotypes, and the treatment pattern in our country, in which newer study tabs can be added for newer studies in these existing patients, as well as if we take new patients also. And then the website is automatically programmed to show you the results in a graphical format, as you can see here. Next is our discussion forum, which is very interesting. And you go to the discussion tab here and create a new post. You can post your case. We have posted few interesting cases, and there you can you can share, and you can comment or follow the posts, and only the members can see and post there and comment also. And we can have the opinions of the experts as well as the international advisory members. Then another interesting journal scan, which all can access, even the students and all can access. You go to the journal scan. We will initially will monthly from the high impact journals. We'll keep on putting in important journals and articles which are relevant to our practice, and you can read those the summary of the articles on the go. So after that, we'll almost weekly planning to update this journal scan, any new article that is coming. Then IBD latest news section, which can be browsed in the tab in the first yellow tab. Browse the IBD news. Then to stay tuned with the latest news, research, as well as newer drugs and all. Next. So our journey started 2 years back, and right now we are ready to launch it. And this reminds me of the old African proverb that if you want to go fast, then you go alone. But if you want to go far, go together. So it's our collaborative effort. Let's take it forward. So please log on to www.ibdenc.org today and register and become a member to access all those features of the personalized registry as well as the discussion forum. Over to you, sir.
Thank you, Partha. Thank you very much for introducing the platform to us. So you see, we have over 200 countries now, all very actively together, coming together into this. And before we actually go to the lectures, we'd like to invite some of our key opinion leaders of gastroenterology in our country to give their comments, and they're very close friends, association for very long with us. We'll start with Dr. Randhir Sood, who is presently the Chief of Gastroenterology, one of the leading gastroenterologists in the country, Chief of Gastroenterology and Director of the Division of Gastroenterology at the Medanta Hospital, New Delhi. Randhir, waiting to hear from you.
Yeah, Nagi, I think it's a great initiative and was the need of the hour, because this is a disease which was prevalent, and we all were following the protocols which originated from West, and we never looked at our own issues and peculiarities of the disease pattern in India and then emerging countries. I think this is a great initiative, and this will go far in creating a collaborative effort in having better understanding and better management of these diseases. And also it will be a good forum for training of the gastroenterologists and the postgraduates. And I really congratulate you and your team for taking this initiative.
Thank you. Thank you, Randhir. Thank you. Thanks a lot. These are very kind words. And we next invite Dr. Ajay Kumar, who is the Chief of Gastroenterology and the Director of the Gastroenterology Institute at the BLK Hospitals. He is also the founding member of the Crohn's Colitis Foundation of India. And Ajay?
Hello, Nagi. Yes. Nagi, it's actually a wonderful day, and congratulations to you, Rupa, Partha, AIG, to have set up this platform where everybody can interact. Nice to see that it is not only the doctors, it's the patients, and everybody can be involved in this. And of course, to have an individual registry is another brilliant idea. I think it's something which is a huge task and has been done. And my congratulations to you. And I think we were looking forward to this for a long time. And that's a desire, a long time desire, which is fulfilled today. Thank you very much for doing this.
Thank you, Ajay. Thank you, Ajay. Next we have Dr. Mahesh Goenka. Mahesh is one of the leading gastroenterologists again from our country. He is currently the president of HCI. He is from Apollo Gleneagles Hospital in Calcutta. Mahesh, you are there?
Yes, Nagi, can you hear me?
Yeah, we can hear you, Mahesh.
Yeah, Nagi, I think not being repetitive, I must congratulate you. And what I think is that what Dr. Azad was saying, that we must, if we form a group like this will not only help in registry, doing some multi-center trials, but I think it will put a lot of pressure on the pharma industry to have a pressure on them to come out with medicines at a lower cost. I think Dr. Azad made a very strong point there, that we need to get these biologics at a lower cost, and I think this platform can also be to stimulate them and to put pressure on them to come out with drugs at a little bit low cost. So congratulations, Dr. Azad, Dr. Nageshwar Reddy and the AIG team for another great initiative. Thank you.
Thank you, Mahesh. As you rightly said, I think the ENC lobby can be very powerful, both in terms of influencing the pharma companies and also influencing individual governments into the policies with IBD. And we hope that as we go along, as this becomes very strong, we can make this political lobbies to influence what is happening in each country. We have next Dr. Govind Makaria. Govind is a professor of gastroenterology at the All India Institute of Medical Sciences. He is also one of the leaders in this area, both small bowel and large bowel diseases. He is currently the secretary of Indian Society of Gastroenterology. Govind?
Very good evening, everyone. Many congratulations to Dr. Reddy, the AIG team, Rupa, and all the colleagues at AIG and all the colleagues at in this ENC forum. Certainly, this is a wonderful initiative, and this is how the world has progressed. Joining hands, collaboration with each other, that makes a difference, and this is a wonderful opportunity. As we know that the IBD is now increasing in whole of Asia, and also in other African countries. So joining hand together will give or provide new opportunities for collaboration and resolving some of the important issues which are relevant to this part of the world. Thank you again for invitation, and many congratulations for a wonderful collaborative initiative.
Thank you.
Excellent.
Thank you, Govind. Thank you very much for those kind words. And lastly and not the least, of course, from South we have Dr. Jayanti. Dr. Jayanti is not only a leading expert in this area, an outstanding teacher. She's a consultant, senior consultant in Chennai. She's been with us for very long, and she's one of the few people who very early on did research in the incidence of IBD in different races. When she was in UK, she published this very important paper to show what happens in Asians in UK. Jayanti, thank you very much for being with us this evening.
Thank you very much, Dr. Reddy, and heartiest congratulations to your team, and of course inclusive of Rupa. It's a wonderful initiative, and I think it's going to help us, many clinicians like us, to help us sort of many of our patients where we have difficulties in making a diagnosis as well as in management. So I wish the entire team all the very best. I'm sure it's going to throw a lot of light as well as in getting a lot of information on different types of IBD presentations across the globe. Wish you all the best. Thank you.
Thank you very much, Jayanti. Thank you for those wishes. We also have many leaders from different countries who are actually in this program who are also watching. We have Dr. Farooq from Bangladesh. I don't know whether Farooq is on, whether he'd like to say something before we go on further. Dr. Farooq is the president. Farooq is the president of the Bangladeshi Society of Gastroenterology. Farooq?
Thank you, sir. Thank you, Professor Reddy and your team for, especially Dr. Rupa, for arranging such an excellent meeting on IBD, which is also emerging problem for our nation also. So we are very happy, and we are really grateful to you and your team for allowing us to see such an excellent meeting and to have interaction with you people who are dealing with this new emerging disease even in Bangladesh. So, and I also thank all other participants, all other experts in this field, in this region of this country, and including Professor Simon Travis, who is one of the very eminent author in this field. So thank you everybody for arranging such an excellent and wonderful meeting for us.
Thank you, Farooq. Thank you very much. Before we actually go to the very exciting lectures that we are waiting for the next 3 lectures, before that we'll have a short video. The lectures are going to be moderated by Dr. Ida Ilmi, whom I introduced already. She is a professor of gastroenterology and heads the unit at University of Malaya in Kuala Lumpur. She has done a lot of work in this area and is very active in the ENC. So she is going to moderate along with Dr. Rupa. Before we go for the lectures, we'll have a short video of the ENC members. Can we have the video, please?
IBD is rapidly increasing in many countries.
IBD patients in low-income countries
need more innovative approach for better care.
It is time for all of us to collaborate and help our patients.
We can do that by sharing our knowledge and experience with each other.
IBD Enc is a global initiative
to bring professionals like us on a common platform.
Let's come together for the future of our patients. Let's come together.
Let's come together.
Let's come together.
Let us come together.
Let's come together.
Let's come together for a future of our patients.
Let's come together for the future of our patients.
So let's come together for the future of the patient. This is the theme of ENC, and now we'll go on to the lectures, and I'd like to hand over to Dr. Rupa and Dr. Ida Ilmi to moderate this session. Ida?
Hello.
Thank you.
Hello, everyone. Hello, Nagi. Thank you for the kind introduction, and it's great to see all the familiar faces, even if virtually and not in the flesh, as I was saying. Can you hear me?
Yes, we can hear you.
Okay, great. Okay, so I think without any further ado, I'm just going to introduce our keynote speakers. The first one really needs no introduction, and this is Professor Simon Travis, who is a consultant gastroenterologist and the Translational Gastroenterology Unit in John Radcliffe Hospital in Oxford. He's held many key positions, one of them being the past president of ECHO, European Crohn's and Colitis Organization,
and really has been responsible for many landmark papers in inflammatory bowel disease. Really is a good friend as well. So without any further ado, Simon's going to be talking about management of IBD in the COVID era. Where do we stand? Simon?
Well, Ida, friends, what a great privilege it is to join this meeting and pay tribute both to Dr. Rupa, Dr. Reddy, and of course Dr. Azhar Bhupan for supporting this initiative. And I'm talking today on the management of IBD in the COVID era, which has really completely changed our perspective on how we manage our patients with IBD. Inevitably, there is a series of conflicts, safety in numbers, I always feel. I'm going to quickly go through some science and then on to the practicalities. And the virus, SARS-CoV-2, of course, is the name, whereas COVID-19 is the disease. It has spike proteins, these little projectiles, which interact with the ACE2 receptor, which is expressed in the mucosal membranes, and that's how it gets access. Of course, you can get GI symptoms, and what Jackson Sanghi in Oxford showed was that if you had inflammation, especially in ulcerative colitis, where the green inflamed areas, the red inflamed areas versus the green uninflamed areas, you've got higher expression of ACE2. So ACE2 expression, which is the key receptor for SARS-CoV-2 to attach to, increases in patients with ulcerative colitis, increases with more extensive disease, and increases with more severe disease. And so you would reasonably wonder whether IBD might lead to worse disease. One of the other problems is you get fecal oral transmission, and there are two phases from the viral response phase, where it may be asymptomatic in many people, especially younger people, and then the more severe post-inflammatory response phase. And this is where some of the agents we use for treating IBD have come into their own. And Andrew Brent, my colleague in infectious diseases in Oxford, will be touching on some of those. So some brief questions, because time is limited. Are patients with IBD susceptible more susceptible than others to the virus? What are the patient perspectives? And does COVID affect the course of IBD? What about medications, and what should be done for patients with IBD or suspected to have COVID? And then how do we get back to normal? And I'm grateful to Dr. Parimal Lawati, who may be on the line from just for sharing some of these thoughts. So Silvio Danesi and Laurent Perabilo published just recently the prevalence of COVID-19 in their 6,000 patient share between Nancy and Milan, and the incidence about 0.25%, very similar to that in the overall population. So probably there is no increased risk of actually getting the disease. However, the government's done a good work in raising the anxiety amongst patients, and this study from Germany, which had a very low incidence and prevalence rate of COVID-19, has really frightened our patients into agreeing that they're afraid their medication would worsen the disease, especially on steroids, let alone biological agents, and they're really scared about getting the disease compared with controls. But there's no impact of the disease on relapse unless medication is stopped. And one of the key messages to our patients is that they should continue their medication. In Wuhan, children a quarter of the children stopped their anti-TNF infusions, and 21% experienced a relapse, and of whom a substantial proportion were admitted. Similarly, in South Korea, there's a 23% relapse rate after delaying infliximab for a few weeks. And I think that's an important message. Main impact has been on the approach to care with the physical distancing, and here I am in Oxford and others calling in from around the world, but we've had telephone clinics, stopping routine endoscopy, change in referral pattern, and a change in our approach to treatment. We identified those patients at the highest risk, about 560 of our 3,400 patients, and advised them to shield, to isolate at home. We emphasized the importance of digital monitoring through a system we introduced 2 or 3 years ago, and about which I've spoken in India and elsewhere, and introduced a home fecal cow protection service with the help of ferrying, so that we didn't have to have stool coming into the lab. Stopped elective endoscopy and elective surgery, and relocated our infusion service. This is the typical readout of our true color system, looking at symptoms of the SCCI, so validated index, and quality of life. And you can see as symptoms get worse, the quality of life deteriorates. And it's a red, amber, green. This is daily symptoms. These are patient-reported data, patient-entered data, fortnightly quality of life, and 3-monthly patient-reported outcomes. But where we use that to advantage was in fact in people who are well, all in the green zone for symptoms of quality of life. You don't need to see these people in outpatients, and so we called them and extended their appointment to reduce the footfall in hospital. And you can do that through mathematical modeling that we achieved, and you can do it with confidence to predict the need for escalation. Many of us contributed to the Secure IBD registry set up by Mike Kaplan and Ryan Nagaro in the States. Almost 2,000 cases of IBD and coronavirus reported now. Fairly few, and I'm sorry I haven't put the Indian data, I meant to put the Indian data into, but with a quarter hospitalized, but no overall increase in the mortality amongst those hospitalized, and no signal for the impact of therapy. Guidance, of course, proliferated from multiple societies, including guidance on endoscopy. And just to touch on endoscopy, in particular, we try to avoid doing routine endoscopy for mild or moderately active disease, monitoring through fecal cow protection and other measures. And in particular, rather than doing full colonoscopy because it's aerosol generating, to do a flexi. And if you're suspecting Crohn's as a new diagnosis or ulcerative colitis, using non-invasive imaging. Of course, acute severe colitis continues, and the worry is that patients may be reluctant about presenting or coming to hospital, and the process of screening for infection, asking about respiratory symptoms or other factors which may increase the concern before testing using nasopharyngeal swab until the rapid assays come around, and then following that through to either make an established diagnosis, admit them to, if they've got COVID-19, to a COVID positive ward, otherwise treating them conventionally to start treatment. Precautions, not only pre-testing, but also the reducing list size, reducing the throughput, and ensuring that everybody, both patient and doctor, were wearing PPE. Sue has worked with David Rubin and colleagues in Australia to produce some NICE guidelines on the, NICE as in the conventional word, NICE rather than NICE as in the institution, guidelines on the medication. Adherence matters to prevent disease flares. This is a lift from Boris Johnson, hands, face and space, emphasizing to our patients the importance of hand washing, wearing a face mask, physical distancing, fundamentally important to protect them and of course protect others. Avoid systemic steroids, budesonide's okay, avoid starting immunosuppression, and be aware of the need to be up to date with vaccine. If somebody does need treatment for COVID-19, being aware of the potential interactions. I'm just going to flick through some of the areas of our specific treatment, but the importance is keep people down in the low conventional zone, and optimizing mesalazine therapy is fundamentally important to preventing relapse, and it makes the point here in this Lancet article, the higher the dose of oral 5-ASA is more effective in reducing the risk of relapse. That's more than 3 grams of 5-ASA daily, and making sure patients take their treatment. Sue's article in APT very nicely summarizes the evidence behind some of the risks for viral infections, increased in patients with on prednisolone, and because of that, focus on budesonide and considering tapering steroids or switching. Immunomodulators while most patients can continue on a stable dose, then to avoid starting thiopurines. Biological therapy, on the other hand, appears relatively safe, but initiating subcutaneous rather than infusion to avoid or to reduce health facility contact. And if patients test positive, then to withhold until the infection clears. Just to give you a case by way of example, I'm conscious of time. 26-year-old journalist I saw just last week, UC diagnosed confined to the rectum just last year, started on pentasa, got better, then she relapsed in spite of adherence.
Simon, can you increase the volume a little bit? We're getting a lot of messages.
Are you? I'm terribly sorry. I'm usually than the other ones. Is that okay? Is that better?
This is much better. This is much better. Thank you.
Sorry,
Thank you, Simon.
No, that's okay. I apologize about that. And then she was elsewhere in the UK, treated with prednisolone rather than budesonide, and advised to go on to azathioprine, and came for a second opinion. And the simple expedient I did was to introduce topical tacrolimus to treat her proctitis, and then to bridge that to vedolizumab and achieve success. And it's just a matter of just thinking outside the box and to think of different ways of achieving the disease control. What about the future? The day after the night before, I've called it, and Sylvia and Laura, who've been, and Sue is co-author on this with Bruce Sands from Sinai, have produced a nice review in Nature Reviews GastroHep. And really, whereas we always used to have face-to-face consultations, telemed is here to stay. Although patients don't necessarily like it, we're going to have mandatory PPE, but try and introduce home fecal calprotectin. Physical distance is here to stay. Look at non-invasive monitoring and physical distance in infusion clinics and outpatients is fundamental. Of course, as we get back to normal, we'll be focusing on priority surgery. And although laparoscopy has in many cases been put on hold during the pandemic because it's aerosol generating, we'll return to laparoscopic procedures. So just to conclude, the new normal will never be the old normal, but grasp that opportunity to move forward. Recognize the limitations of advice at a distance, but don't let it become distant advice. Optimize maintenance therapy, especially optimizing oral mesalazine. Higher doses do better, and sachets are often preferred. And if you want to avoid immunomodulators and keep the cost down, then topical therapy as well as oral therapy is a way of achieving that. Fecal calprotectin, ideally at home for monitoring, and if you have access to digital monitoring, that helps. Use systemic steroids with low systemic bioavailability, and an anti-integrin is preferred to anti-TNF for maintenance if you have access to that. So that's my view on IBD and COVID era, and I think we'll take questions at the end, and I apologize if the audio didn't come across as well as it should do to begin with. Thank you very much indeed, Ida. Back to you.
Thank you, Simon. I think we'll take questions at the end. Rupa?
Yeah, I think we'll take questions at the end because Professor Andrew has a very busy schedule, and we are actually lucky to have just got him right now. Over to you, Ida.
So, so the next speaker is Dr. Andrew Brent, who's a consultant in infectious diseases and general internal medicine in Oxford. He is really going to give us an update on everything we've been waiting for, which is the COVID vaccine and what are the developments with regards to this in Oxford. Dr. Brent, welcome.
Andrew, you're on mute.
It does help if I unmute myself. I hope you can see my slides. I'd like to start first of all by thanking you for the very kind invitation and apologising that I'm on acute medicine today, so I have to get back down to the front door after I've done this. But I hope to give you a little bit of an insight into what's happening in Oxford on the vaccine front. It's a great pleasure to talk to colleagues in India. I spent many months living and working and travelling in India many years ago, although I never made it to Hyderabad. But I have fond memories and would love to come back sometime in hopefully happier future times. I need to start really by emphasising that the work on the vaccine that I'm presenting is not my work. Although our clinical service supports the vaccine study, this is work that's run by a team of people based at the Jenner Institute and the Oxford Vaccine Group, including Sarah Gilbert, Andrew Pollard, Adrian Hill and colleagues. Getting straight to the meat of it, I'm going to talk about the Oxford vaccine, but I think it's useful to start by stepping back and thinking about the different vaccine approaches, because the Oxford vaccine is just one candidate vaccine at the moment, and one of more than 100 that are being developed and explored around the world. So what are the different approaches and where does the Oxford vaccine fit in? One of the ways of doing it is to take virus, grow it and attenuate it, and that's an approach that's being done through a collaboration that includes the Serum Institute of India. Another is just to get inactivated virus. Again, you need quite large amounts of that. Replicating viral vectors are increasingly important in the repertoire of vaccine development, and that includes a non-replicating virus, which is the approach used by Oxford, and I'll talk more about that in detail, of course, but also replicating viral vectors are used for some diseases, including the recently approved Ebola vaccine. Nucleic acid vaccines are probably one of the most exciting ideas that are being pursued. And this is the idea that you provide only the nucleic acid, either DNA or an RNA, depending on the approach, and then allow the host cells to manufacture the gene product and express it to elicit an immune response. And there are at least 2 RNA vaccines currently in development for COVID. One you may have seen a phase 1 study published in the New England Journal a couple of months ago, and there's another vaccine being developed by Imperial College London. And one of the advantages of this approach is that you can upscale manufacturing actually quite quickly, which is going to be key in the COVID-19 pandemic response. Protein subunit vaccines obviously very widely used and are the type of vaccine used for many of the vaccines in the expanded program of immunization and others. And then another approach is to present antigens on empty virus shells, which like a pseudovirus, and that's also being explored by some groups. But the Oxford vaccine is using this approach of an inactivated viral vector. It's using a chimpanzee adenovirus, Oxford 1 as the vector, and inserted into that virus is the RNA of the spike protein. Importantly, the virus itself has been inactivated, so it cannot replicate and therefore is incapable of causing disease in the people who are vaccinated. So why has the Oxford vaccine got so much attention? Well, it's because it's probably the leader of the pack in terms of the stage of development, and that's because they had a head start. A lot of studies have already been done by Oxford, GlaxoSmithKline and others using simian adenoviruses, and so there's a wealth of safety data already on these viral platforms, and that includes the ChAd-Ox1 vaccine, which is being used, the ChAd-Ox1 adenovirus, which is being used as the vehicle for this particular vaccine. More than that, the group in Oxford, led by Sarah Gilbert, is already in the process of developing a MERS vaccine, and I'll talk a little bit about MERS in a moment in my next slide and why it's relevant. But they'd already made some progress in showing that this was protective using the ChAdOx1 vehicle in transgenic mice and in non-human primates, and we're moving on to phase 1 studies in humans when COVID hit. So it was really a springboard onto which the COVID vaccine development followed. So why MERS? Why is it important? Well, those of us in the infectious diseases world, and particularly those in the Middle East, have been very familiar with Middle East respiratory syndrome for the last few years. It's closely related to COVID, although it's a beta coronavirus, although it's a slightly different lineage. It's lineage C as opposed to lineage B for the SARS-CoV-2 virus, which causes COVID, and they bind different receptors. We also know a lot more about the epidemiology of MERS, which carries a much higher mortality, but thankfully hasn't led to prolonged human-to-human transmission, and so hasn't had the same epidemic and pandemic potential, which unfortunately we've seen with COVID. But nevertheless, it's a close relative, and so progress on the MERS vaccine front is highly relevant when we're thinking about a COVID vaccine. So let me share with you the MERS vaccine data first, and then we'll move on onto the COVID vaccine data to date. So this is some of the non-human primate data. This is using macaque monkeys. If you look at the part A of this figure, I'll take you through it. So the first line, the red, is a prime boost arm of the study. So all the animals got 2 doses of the vaccine, a prime dose and then a boost dose. So at minus day 56 here, that's the prime dose. They then get an evaluation, that's where the E's are, and then 28 days before the challenge, they get the boost dose of the MERS vaccine. Then they get challenged and they continue evaluation until they're neutralized at the end and examined. The blue, the second column, is a single dose regimen, so there's no prime. It's just the single dose, 28 days before the challenge, and then there's a control here, which is the vaccine linked to a green fluorescent protein, so no MERS antigen. I should have said that the MERS antigen used here is the spike protein, so analogous to the spike protein that we're using in the COVID vaccine. So the graphs below, the first one shows antibody titers, and you can see that, as expected in the control group, that's the green dots, there's no antibody response. However, there is a good antibody response in both the prime and the prime boost vaccine to the spike protein, and it's higher in the 2-dose regimen. If you look at viral neutralization on the right, you can see a similar picture. Again, the responses are better in the 2-dose regimen. So they were also able to demonstrate clinical endpoints in this study of primates. On the left, this is the clinical score in the macaques that were challenged. The higher the score, the worse the clinical syndrome, and you can see that the high scores are mainly in green. Those are the non-vaccinated or the control vaccinated group. In the group that got the 2-dose regimen, very few of them had clinical disease. There were 1 or 2 with mild disease, and somewhere in between is the 1-dose regimen. The second graph on the right shows the degree of hypoxia, so the change in oxygen saturations following challenge. And again, you'll see that quite a lot of the green dots show a significant reduction in oxygenation, relating to lung parenchymal disease. But in the vaccinated group, there's very little evidence of hypoxia. If you look for virus, again, this is time on the x-axis post-challenge. You can see that there's some infectious virus isolated that could be cultured early post-challenge, but not much later on in any of the groups. But if you look for evidence of replication, going back, evidence of replication by looking for messenger RNA, you can see that whilst there's quite a lot of replication in both the upper respiratory tract, this is here, nasal, tonsillar, oropharynx, and trachea, in the control group, and in the lungs, these are the green dots, in those that got 2 doses, there was no evidence of viral replication in either the upper or the lower respiratory tract, and only a little bit in the single dose regimen. Macroscopically, if you look at the lung, probably best to look here at the right first. You can see the lung from a macaque that has been given the control vaccine and then challenged with MERS, and you can see that there's macroscopically bronchopneumonia, and that's reflected here in the histology. But if you look at the 2-dose regimen, although you can see a probably appropriate inflammatory response in some of the lung tissue, there's no evidence of bronchopneumonia, and that was reflected in the in the clinical scores and oxygenation saturations, which were good. And again, a little bit of inflammation in the group in the middle, which had a single dose. So having done the non-human primate studies, they were already underway with a first in humans phase 1 clinical trial when COVID came along. So this is the phase 1 study of the MERS vaccine, which was published in Lancet Infectious Diseases earlier this year. On the left, it shows the antibody responses, and you can see that compared with baseline, and this is obviously a logarithmic scale, there was a good and sustained antibody response, sustained out to a year, in all the groups, and these were groups with escalating doses. A similar situation was seen with the T-cell response, if you look at the graph on the right. So again, compared with the baseline pre-vaccination, there's a significant and sustained increase in T-cell responses as measured by ELISpot following vaccination. So, what about COVID? That's MERS. We're now moving on to COVID. So this is a similar platform, but instead of the MERS spike protein, we've got the SARS-CoV-2 spike protein in the same viral vector, chimp adenovirus OX1. So this is some of the data from a similar non-human primate study. Again, a similar study design, although here we've just got a single dose of the vaccine. The red here is the COVID vaccine, so vaccine given here, V at the beginning, and then a challenge, and then follow-up and neutralization at day 7. This time it's blue for the controls, and again that's a green fluorescent protein instead of the spike protein. And if you look at the graph on the left, what you see is that, as expected in the control group in blue, there's no antibody response, but there's a good antibody response in the red vaccine group. If you look at viral neutralization, that's the second graph here, C, again you can see that there's good viral neutralization in the vaccinated group. And looking for T-cell responses, so this is spot-forming units in an ELISpot test, looking at peptides across the length of the spike protein insert. You can see that although it wasn't seen in all of the animals, there is in some of them a reasonable T-cell response, but of course not in the controls. This is mirrored by the clinical and histological picture. I've just shared the histology here. If you look at the top row, this is actually the control group, and what you can see is here there is some bronchopneumonia evident, and that's quite evident macroscopically. And on the right-hand panel here, you can see by immunofluorescence there's virus in the lung. By comparison, in the vaccinated group, no bronchopneumonia macroscopically or histologically, and no virus to be seen in the lung. And really importantly, these studies didn't show any evidence of immune-enhanced disease. There was quite some concern at the beginning of vaccine studies that there was a potential for vaccine-enhanced disease. This is a concept that's best understood, although even then incompletely, in dengue, where infection, as many of you will know, previous infection may lead to enhanced disease with subsequent infection. In dengue, that's usually with a different serotype. But there was a similar vaccine enhanced disease has been seen in some other infections, and there was concern it might happen in COVID. But thankfully, no evidence of that so far in the non-human primate studies that have been done in both MERS and in COVID. Very recently, the breaking news has been the publication of the first phase 1 study of the Oxford COVID vaccine, and this was published in The Lancet on the 20th of July. And this was a study of over 1,000 participants, many of whom are also in phase 2-3 studies that are ongoing, looking at safety and immunogenicity of the vaccine. And I'll share with you those results briefly. So looking at safety, first of all, and reactogenicity, there was no evidence of severe reactions. The vaccine was fairly reactogenic with both local and systemic reactions. And of course, there's a balance here. In developing a vaccine, you want it to produce an immune response, and therefore you expect that there might well be some reaction, local and or systemic, to the vaccination. And we see that here. So if you look at the top row, this is just looking at local reactions. So induration, itch, pain, redness, swelling, tenderness, and warmth. And that's compared on the lower line with the reactions in the control group, which in this study was meningococcus ACWY vaccine. And what you see is that there's local reactions in both, but they are a bit more frequent in the COVID vaccine group, and in some cases slightly more severe, but the vast majority of them were mild. That's in the yellow, and a small number moderate. Important to say, I'm showing you for brevity here the data in the group that got prophylactic paracetamol. There was a protocol amendment to add that in because of the slightly higher rate of reactions in the vaccine group. There was slightly higher reactogenicity seen in the group that didn't get paracetamol, but still no severe and mainly mild reactogenicity. Looking at the systemic reactions, again, you see that several, sometimes up to about half of patients might have had some systemic symptoms with chills, sort of influenza-like illness, not surprisingly, fatigue, but that was mostly short-lived, mostly mild, always self-limiting, and none of them were severe. Again, a bit more than in the control group with the meningococcal vaccine. Looking at the immunogenicity, again, these graphs are showing days from vaccination over the first 56 days, and the antibody responses of the control group are shown on the left. That's compared with the vaccine group here in the second graph, and you can see that there's following vaccination, there's a fairly good antibody response here, which sort of seems to peak about 14 days or so after vaccination, which is similar to the kinetics of natural infection. And if you look at the T cell response, one sees a similar picture. If you, I think that's my next slide. Here, this is showing the responses in the prime boost. So this is in a small number of patients who got 2 doses of the vaccine. And again, you'll see a similar, if anything, with the eye of faith, possibly slightly higher responses. And importantly, the magnitude of these antibody responses seem to correlate reasonably well with natural infection. So the graph on the right shows the magnitude of antibody responses seen in natural infection from a different group of patients, but the data published in this study. Viral neutralization assays, and there were a number of different assays used in different labs in this study, but essentially all showed the same thing, that there's evidence of virus neutralization, which is reassuring. And if you look at the T cell responses by ELISpot, again, compared to the control group, which is shown here on the left, there's evidence of reasonably good T cell responses within the first couple of weeks in both the prime and the prime boost groups. So what's happening? Well, thankfully, from a public health point of view, but slightly more difficult from a vaccine development point of view, the number of cases in the UK has fallen very considerably since at its peak in April, and that's obviously made it more difficult to reach the endpoints needed in the vaccine trial. So although a large number, over 10,000 people, are being recruited into the UK vaccine trial, the vaccine has been extended to other sites globally, including in Brazil, where, of course, unfortunately, there is an ongoing very serious epidemic. South Africa, and there's work underway to launch it if the hurdles can be overcome in other countries around the world, including potentially India. Unfortunately, the nature of the pandemic and of vaccine production means that one can't wait until you've got a vaccine with proven efficacy before starting to manufacture it. And so there's a degree of risk that needs to be assumed in manufacturing vaccine before then. This is partly underwritten by the UK government, but also by a number of international organisations that are collaborating with the Oxford Group, and that includes industry, AstraZeneca, the Coalition for Epidemic Preparedness Initiatives, Gavi, the Global for Vaccine Alliance, and the Serum Institute of India. And the aim is, and the expectation is, that they'll be able to produce hundreds of millions of doses by the end of 2020. And really importantly, they've made a commitment to produce at least 1 billion doses for low and middle income countries, and to be able to provide them at cost. So it's a work in progress. I, like you, am waiting with bated breath to hear what happens with the vaccine trials as they progress. And of course, not just with the Oxford vaccine trial, but also with the other vaccine trials that are happening around the world. It's quite possible that we will have more than one effective vaccine. We certainly hope we'll have at least one, and it's quite likely, if we have more than one, that we will need all of them in terms of upscaling vaccine production to be able to mitigate the evolving pandemic. I just want to finish with my thank you slide, because I'm presenting work that really is done by others, just like to thank everybody again for inviting me. I'm happy to take a few questions.
Thank you very much for that really very interesting talk. I think obviously a phenomenal amount of work has gone into this, and considering it's such a big thing, I think we're really, all eyes are on Oxford and the whole team for producing this vaccine that the whole world is waiting for. I think we did say we're going to take questions at the end, but just a very quick one. When do you think the earliest would be if this vaccine works out? Would it be,
well, I mean, of course, it depends. It depends on when they can meet the vaccine endpoints. But given the progress in recruitment, the team are hopeful that they will have an answer by the end of the year. Of course, we don't know what that answer is going to be. The initial data is promising, but we know that that phase 1 results don't always translate into efficacy in phase 3 studies. So we will have to wait and see, but the hope is that we'll have some answers by the end of the year.
Okay, thank you very much.
I'm afraid I won't be able to stay for the question and answers, so if there are
there any burning questions? Maybe I'll take one before. Rupa, is that all right?
Yeah, so question from all Indians all across this place. Andrew, want to know, when will the pandemic end? Any astrology on that?
I can probably answer that in relatively quickly in 3 words. No time soon. I think what's very clear, and it's been, I think, clear to many of us since early this year, is that because of the pandemic potential of this, which has now very, very clearly been demonstrated, we're never going to get on top of it anywhere until we've got on top of it everywhere, because and pandemics par excellence show how interconnected we are. So that we're seeing this at both an international and a national and subnational level, so that even where we're getting control of the virus, we're getting local outbreaks. We're seeing that within, I know we're seeing that in the UK, we're seeing it in other European countries, and we're seeing it in other countries around the world. I'm sure the situation is no different in India. And even if an individual country were able to get complete control of it, again, we're so interconnected that it seems likely that you would have reintroductions from other countries. So unless and until we have got a very effective, widely available vaccine which provides prolonged immunity, it seems unlikely we're going to get rid of it, and we're going to require a combination of all the personal and the public health interventions that we're using at the moment, including hand washing, not touching face coverings, keeping physical distance, and the track and trace approach to contact tracing and isolation of infected individuals. Of course, we hope that in parallel with that, the other strand of active research will lead to further improvements, and that's improved therapeutics. You know, one of the reasons that this has become such a scourge is because it's so many people, because it's so infectious and is associated with a relatively high mortality. So if we can reduce mortality by having effective treatments, that of course might limit its impact. I don't have time to talk about that arm of things today, but as you're probably aware, some progress has been made in Oxford, which led the recovery trial, showing the impact of dexamethasone with a third reduction in mortality in intubated ventilated patients and a fifth reduction in those who require oxygen. So we've made some progress in the last few months. And of course, the wonderful thing about dexamethasone is it's cheap and widely available, so highly relevant even to low resource settings.
Thank you very much.
I have a question. Can I ask?
Yes. Okay. One question, a quick one.
If you believe that fecal transmission of this virus occurs, do you believe that inactivated or attenuated vaccine would be better than simple RNA vaccine because of the herd immunity that happened in polio?
I'm so sorry. My connection cut out briefly in the middle of your question, so I only caught the very beginning and the end, but not the important middle bit. Would you mind briefly repeating?
Yeah. If you believe that fecal transmission of this virus occurs, do you think that inactivated viral vaccine or attenuated viral vaccine would be superior because of the herd immunity as occurred with polio as compared to an RNA vaccine?
I think it's an interesting question. It's an interesting question. I don't think we really understand to what extent fecal oral transmission contributes to the overall epidemic. On the basis of what I've seen so far, it's likely to be a very minor contribution. But of course, I guess we're still learning. I suspect that of all the factors that might influence the effectiveness of a vaccine and its impact on the pandemic, that is a very minor consideration.
Thank you very much. So thank you so much, Dr. Brent. It was really nice to meet you. I think everyone is really very excited, very enlightened by the talk. So we hope to hear from you again on the latest updates at some point.
Great. Thank you very much for the invitation.
So moving on, we're going to go on to last but not least, and that is the beautiful Professor Sue. Sue is the professor in the Institute of Digestive Diseases in Chinese University of Hong Kong. As we know, she's a key opinion leader and has done a lot of research in inflammatory bowel disease, and as you can see, is a co-author of multiple papers, as Simon pointed out from the previous talks, for example. So Zio's going to be talking about something that I think is really very relevant to us. It will always be relevant to us, maybe not in Hong Kong or Singapore, but to the emerging nations, many countries, emerging nations, which is challenges in IBD management in low resource countries, the way forward. Zio?
Thank you very much. Ida, can you hear me?
Yes.
Yeah, good evening, everyone. It's really, truly great to see so many friends of them online. And I have to say, massive congratulations really to Rupert and Nagi for this ENC platform. I'm really thrilled to see it being inaugurated by Dr. Azad and being launched after so much of effort. And I believe that friendship and this network will sort of flourish over time. So my task today is really to share with you some of the challenges. Interestingly, Rupert mentioned about Hong Kong being a sort of a maybe higher resource countries. I have to tell you, when I first moved from the UK to Hong Kong 10 years ago, biologics was not a reimbursed item, and this is kind of the practice that we have to face in real life. The issue is that we all know that in Crohn's disease, there's a small window of opportunity to capitalize, to alter the natural history of the disease. And all the clinical trials has taught us that if we treat earlier, we have better remission and we have better healing. And we've really seen this across infliximab, adalimumab, and all the different biological anti-TNF trials, and I'm sure with the newer molecules as well. And you could see on the left here are the proportion of patients who achieve clinical remission, with the bottom, the length of duration of the disease. But welcome to reality, because we well know this is not the case, because this is courtesy of Shu Cheng Wei from Taiwan, showing us that the discrepancy of medical insurance system for IBD. And you could see, I've just given some examples of Malaysia, India, Singapore, and Hong Kong and China. And on the top are all the non-biologics, and mostly are free. And we well know, the reason for that. But if you look right at the bottom, for even the anti-TNF drugs, I think these may be old information, but nonetheless, many are not reimbursable, and patients still have to sort of pay out of their pocket for many of these drugs. So on top of that, we are facing a real challenge, and this is, we are now in the stage 2 of the evolution of IBD. We've seen it emerge in the East recently, in Asia, and right now we are having greater acceleration, and I believe this ENC platform will highlight the burden of the disease, which we never knew before we had a network to look at that. And in some of the Western countries, as Gil Kaplan will say, there may be sort of compounding sort of prevalence, whereby it continues to increase and then will decrease over time. But what we're facing here is the great acceleration phase. So there were two sort of platforms 10 years ago with all the friends, either Rupert and people around the Asia Pacific region, to build out access. And access with 13 countries, we really found that China and India have the highest incidence of IBD, at least in Asia. And you could see regions with a high population density, maybe a reflection of urbanization, had a higher incidence of Crohn's disease and ulcerative colitis. And clearly what has to be applauded is this ENC nation, which will, I believe, in the next 10 years, bring to the forefront all our friends from the emerging countries into one platform to, I believe and hope to see us dividing the incidence and the prevalence and the disease cause, and also to influence healthcare resources used for our patients. So here we are, when we have globalization, which I believe is the disease of sort of modern society, we will have compounding prevalence. This is going to overshoot the natural growth. Biologics are cost effective, may not necessarily be cost sustainable. This is what we hope to achieve in the next decade. We've seen the emergence of biosimilar and personalized medicine, but certainly the disparity of this care within countries. I have to tell you, not only in Asia, I think even in the West, in the United States, there's a great disparity in terms of socio-economic status and access to drugs, for example, biological drugs. So to address this burden, I see two arms. One is to continue to understand the pathogenesis of the disease to prevent it. This is the holy grail of IBD. One day we can go down the prevention route. But more importantly, what we can do now is to innovate our delivery of healthcare and to optimize the drugs that we can use for our patients currently. So together with these friends, Pav, you've seen, and Rupert, we published this in Lancet GI Hub. Thanks to the leadership of Rupert, trying to understand in resource-limited countries, what are the options we can do actually before you can get access to some of the smaller, newer molecules. And I think there are three new sort of options. Optimize our conventional therapy, consider the use of alternative therapies, and I have to say I've used all of these when I couldn't get access to biologics several years ago, when we still have to treat our patients when they're sitting in front of our clinic. And certainly in some issues to this escalated treatment when we don't really need it. And I know for reimbursement, in some countries, after a year of treatment, you just have to stop. So we need a better sort of planned strategy in terms of doing this. So reliable bodies for remission in ulcerative colitis, I still think they are mesalazines and steroids because they are cheap, they're reliable, they are effective, and they're easily accessible. So this is what I call in terms of buddy. And if you look at the guidelines, for example, the ACG guidelines, we now know, of course, for the first line for ulcerative colitis, it would be budesonide, steroids, or 5-ASA. So in DDW, this year, actually many couldn't go, but with the cornerstone support, we look at some of the latest updates on the use of some of these drugs. Now, this study on the left is one from Japan. It tells us that actually in small proportion of patients who are intolerant of mesalazine, actually if you really challenge them, you can attempt success in over 64%, and also at least in more than half who could not tolerate to start with. So you may not need to give up so soon if you think that this could be still the first line treatment for some of them. And on the right is another study again presented at DDW, so a virtuous poster. It's a post-hoc analysis of 4 randomized controlled trial, and again echo what Simon Travis said earlier on. In fact, they showed that higher dose, 3 grams of daily mesalazine, had a higher rates of histoendoscopic mucosa healing compared to 1.5 grams or so 2 gram dosage. So something worth considering in your daily practice. Now, as Andrew Brand said earlier on, steroids is cheap, is easily accessible in IBD. I am a big fan of steroids. However, I think these are the issues we need to think about when we started steroids on patients. We know of the long-term side effects. The 2 points I want to highlight is avoid dose creep. Every now and then, people will start at a lower dose and think if they go up again, it may actually reduce the side effects. In fact, I would rather go strong and then reduce, because we face the issue of prolonging the course of steroids. I generally will go even 1 milligram per kilogram or 0.5 to 1 kilogram. I never start with 20 milligrams and then it doesn't go up to 40, as I think that defeats the purpose of using a drug effectively. And the second point to make is not too rapid, simple taper, but don't rush it through, because the last thing you want is for the patient to have a sudden relapse. Of course, we need patience by it because of side effects, and also step up if it doesn't work. And now there are new formulations of budesonide, MMX, that is still equally effective in ulcerative colitis as well. This is a new kid on the block, which I believe in Asia, we need to know a lot of it. And of course, in the West, people are also being very familiar with it. NUDT15 is a genetic variant related to thiopurine toxicity. And this has been shown, for example, in an East Asian cohort. Look at this odds ratio, 35 times of getting thiopurine-induced leukopenia if you have this NUDT variant. It is also much more common in the Asian population and has also recently been replicated in the European cohort as well. So how we do it in sort of Asia is there are increasing more studies now looking at the use of low-dose azathioprine. So for example, in this study from Hong Kong, we found that in the Chinese cohort, the patients on standard dose of azathioprine had a higher chance of leukopenia. And this could partly be related to this new genetic variant. And understand that in India, Rupa and other people have also published showing similarly that low-dose azathioprine may actually be equally effective in the Asian population. We have yet got a randomized controlled trial on this, but in real life practice, this seems to work effectively. So this is a paper actually from Japan. It's a very elegant paper. It's one of those that it actually compared patients who had genotyping for NUDT checking before you start thiopurine to look at one group with and one group without checking. And you could maybe see on this graph that actually the cumulative adverse events-free survival was higher in those that it was actually much better in those who had genotype done. So it shows that actually doing so in clinical practice, it can actually reduce the incidence of leukopenia in your patients whom you consider starting thiopurine. Now, I am also a big fan of diet. This has changed my practice in the last couple of years, if this is something I would highlight. We now know that there are many factors that will influence the risk of relapse in our patients with IBD. Prior to 5 years ago, we hardly had any data on diet. We now know that additives, pro-inflammatory food, and those that had a reduction of short-chain fatty acid is no good. And I've changed my clinical practice in consulting and counseling patients. Of course, stopping smoking is important. And here, there are now animal data and also probably upcoming human data showing that specific mixtures of macronutrients and also emulsifiers, these are food additives in the diet, can increase permeability, change the gut microbes, and predispose to intestinal inflammation in IBD. Not only just increase the risk of IBD, but if you have inflammatory bowel disease, you're likely to have a higher chance of relapse as well. The best study, of course, is this landmark study in 1984, published in the BMJ, showing us that controlled trial of elemental diet and steroids. We could see how, it is equally effective as compared to steroids. And the cost of partial enteral nutrition, as you can see, is $12.5 US each day, while the cost of exclusives is $25 US per day. Compare this to the other molecules and neurobiologics we use, I'm sure this is one of the very, very cost-effective measures if desperate and much needed to be used. How do we use it? I think compliance is the issue because it may not be palatable. This is a beautiful study from Ari Levine's group in Israel. In fact, they did a control trial in Crohn's disease whereby they look at two groups. One group is you can have 50% of food and enteral nutrition. And the second group is completely exclusive enteral nutrition. And it shows that actually, even with those who introduce the 50% food, the response could be 85% and remission at 6 weeks was 80%. So this makes it a little bit better for our patients, I believe. Every time I tell someone you have to go on exclusive enteral nutrition with anxious for 6 weeks, and my youngest patient who had this had been using exclusive enteral nutrition for a year. But I think this could actually help our patients actually to manage this much better. And similarly, a beautiful study from Glasgow showing ordinary food replicating enteral nutrition for Crohn's disease. So there's certain food that are very similar to exclusive enteral nutrition. And in this pilot study in healthy adults, they show that the changes in the microbiome and everything was good, and clinical remission can be achieved in a small proportion of patients. So what about fecal microbiota transplantation? Well, this is quite hot. People have been asking a lot about that. There are now 5 randomized control trials. This is a systematic analysis of the 4 RCT, and there are now over 20 underway. It's a little bit more challenging in doing FMT trials now because of COVID, I have to say, and also because of what was mentioned earlier on about the potential of fecal oral transmission. Nonetheless, in these clinical studies, FMT is superior to placebo in inducing clinical and endoscopic remission in active UC. And you could see in this comparison of all the clinical trials, the remission rate is about a third. So this rate, if you compare it to some of the biologics, is relatively similar in that regard. And this is Ajik's study. I know he's online, whereby he looked in his Indian cohort if you can use FMT to maintain remission in ulcerative colitis patients. And the answer is in his cohort, yes. You could see that about 87% actually were able to maintain clinical remission, and half of them are able to achieve endoscopic remission as well. So here is a patient who had very difficult ulcerative colitis, azathioprine refractory, and with FMT 100 mils. The patient, actually, this is a success example. The endoscopic Mayo score was 0, and patient was off azathioprine and maintained on mesalazine. And together with friends from APAGE region, we actually did an international consensus just last year. And I think the key issues is how does FMT really make the microbiome great again? It actually, I think the selection of donor is important, and also the selection of the recipient is important. We need to select the appropriate one. Not when it's too late, but not when someone needs colectomy, then you try this as its last resort. I think this is a high risk. I mean, if this is, so the timing of selecting the right patients is crucial. The future, I think we will see these capsules for using that. At least the lessons we learned now, I think if you're thinking about fecal microbiota transplantation, is effective in induction therapy in mild to moderate, but I think the optimal position in the therapeutic armamentarium is not completely defined yet. It is actually effective in patients with IBD if they're recurrent C. diff. I think this is pretty clear. In fact, there was also just a study published last month on that. The role in Crohn's disease and pouchitis is still less clear. So lastly, I just want to talk a little bit about this escalation of biologics treatment. So in this scenario, it's relevant to world resource setting. And have I done it before? Yes, I have de-escalated some of my patients with Crohn's disease who've been in remission. The data from the STORY trial show us that if you look here, the risk of relapse in patients is maintained on azathioprine, and if you stop the infliximab, the 1-year relapse is about 43%, and the 2-year relapse is about 50%. Subsequently, they published this long-term outcome study, which I believe is important because we want to know what happens many years down the line after withdrawal infliximab. You could see here that after 7 years, biologics still need to be started in some patients, but the outcomes, if you resume infliximab again, about 65% can still achieve remission when you reintroduce, and about 1/3, however, was unsuccessful. There are some factors that are associated with relapse after stopping. If you have active disease, short duration of remission, high CRP, and in the post-op setting. So here was an APAGE guidelines consensus led by CJ Owens and Ida. And I think the key thing is if you want to de-escalate, the few factors I look is apart from clinical is the endoscopic mucosal healing and the normal biochemical markers as well, and the longer term of duration. I would not stop biologic after 6 months or 1 year. In fact, I would definitely make sure the patient has been in remission for at least a year before sort of consider de-escalated. But there are patients who fall into this category that could be successfully, de-escalate. And lastly, there are now rules of biosimilar. Here is one that is presented in GGW of this year. We know that when you switch from the originator to the biosimilar, it is effective. This study tells us that the second switch from a biosimilar to another biosimilar could also be equally effective. As we know, there are now more biosimilars coming out. So the double switch with a single switch make no difference in clinical remission or continuation or discontinuation of other treatments or also adverse events. So lastly, there are just 1 or 2 less conventional treatment. You can see here the list of those that has been used, such as traditional Chinese medicines, such as curcumin. There's one that is presented this year at GGW. This is a randomized controlled trial of acupuncture. And I think one of those that was conducted very well with a nice study design. And this study shows that acupuncture is safe and effective in induce and maintain remission in active Crohn's disease. If you look here, the pink bar is a clinical remission rate. 63% achieve clinical remission and about 21 in the sham, which is a non-acupuncture arm. So curcumin is popular in India, and this is a study we did with Israelis or friends, where we look at curcumin for induction of remission in mild to moderate ulcerative colitis. It seems to sort of work, and about I think 60% achieve clinical response, and about just under half with curcumin treatment. I think in this case, it's 3-gram capsule was able to achieve endoscopic remission. So this is a summary. If you're interested in reading this paper together with Paul and Rupa, there are a few points to take home. One is to optimize your buddies or your current drugs that you have accessible easily to. Nutrition therapy, don't forget, is cheap effective way for treating your patients. Early accelerated setup, the escalation with close monitoring, biosimilar if it's available, and there are many other sort of alternative immunomodulator that I didn't touch on that you could consider as well, and also not to mention complementary therapy. So lastly, diet, because I'm a big fan, I want to finish with that, to say that right now with additive-free polymeric combination with fruit diet, you can achieve a lot of remission in your patients. In ulcerative colitis, it may be a little bit less proven right now, but certainly microbial therapies are becoming up and coming, and for the prevention would be to reduce antibiotics intake when not necessary. So I just want to highlight the secure registry. I want to tell you right now that you could see in the secure registry there are 1,925 IBD cases who had COVID-19 as of, I think, last week. You could see this registry that we would love if friends from India or so from Southeast Asia, when you see a patient with COVID-19 and IBD, even if it's already from last week, last month, or a few months ago, to even enter this. And it takes only sort of 5 minutes. This is an initiative Mike Caperman, John Columbell, and Ron Ngaro and Erica, with the support of AOCC and IOIBD and several other groups as well. And right now, you could see actually 17 cases in India has had COVID and IBD and has been reported onto this website already. And throughout the whole of Asia, there are 150 cases with that in Asia. I believe this is still an underreporting. You can see the 800 over and 700. So it'd be wonderful if we could have more reported cases to understand the natural history and our long-term outcome of our patients with COVID and IBD. So please report your cases. And lastly, the CHK IBD team wants thank you, and I really feel that hopefully we could meet again in person in Hyderabad or in any places in Asia when the COVID is over. So thank you very much.
Thank you very much, Sue, for that fantastic talk. That was very, very interesting. I think there'll be a lot of questions. Rupa, are you there? Shall we take questions first and then have the panel discussion, or should we do it together?
I think we'll follow a pattern. Good evening, I'm Dr. G. N. Ramesh. We'll take the 3 topics that have been covered, we'll take them up one by one, and then we have a panel discussion. I'd like to introduce the panel to you: Dr. Matthew Philip, Dr. Shobna Bhatia, Dr. Uday Ghoshal, Dr. Devendra Desai, Dr. Usha Datta, Dr. Masudur Rahman, and Dr. Ajit Sood. So welcome to the party, ladies and gentlemen. We'll first take up the first talk by Professor Simon Travis, and he spoke at length about COVID and IBD, and he did mention a few points. Does anyone in the panel have any question for Professor Simon Travis? Professor Simon, you mentioned prednisolone, no, budesonide, okay. That came as a bit of a surprise for me, because we were always told that steroids, not okay. So is it, I'd like to ask my Indian colleagues as well, would you feel comfortable using budesonide in patients with IBD in the COVID era, continuing them on budesonide? Anyone?
My picture also there.
Yeah, I tell you.
Yeah.
What you're saying is important. I don't know, are there enough evidence? Obviously, there are no possibly to say steroid is bad, because these are opinion based. So if we know that steroid is rather helpful in treatment of this COVID, particularly severe one who are ventilated, is it possible the steroid would be better? Yes. Are there any randomized controlled trial? The answer would be no.
Professor Simon.
Well, it's a matter of playing for safety. Prednisolone is appropriate to get disease under control, but if budesonide, which has low systemic bioavailability, is available and it is more expensive, then I would use that first. And I think that the point that Uday was mentioning about steroids and COVID-19, of course, as Andrew Brent pointed out, it's only in those patients who have got severe disease in which dexamethasone was found to have an effect. So I think that my recommendation about steroids is that get disease under control, yes, and but I would use the budesonide MMX for ulcerative colitis or the ileal release for ileal Crohn's disease if that was available first. It's just given us a step up towards prednisolone rather than saying avoid it altogether.
Can I add a little bit to that as well? I think, like Simon alluded to, in the dexamethasone recovery study in Oxford, I think the role of the steroid is used for the severe cases, for cytokine storm, syndrome, so who had that. When you look at the data from the SECURE registry, which was about 1,000 subjects by then, I think the important point to make is if you have inflammatory bowel disease and if you get COVID, and if you are on steroids, if you're on more than 20 milligrams of prednisolone, then you have a worse outcome. And in that study, the outcome is defined by more hospitalization, more ICU, and so mortality. So it happens that in that cohort, it was consistently shown that high dose steroids, at least for prednisolone, was associated with worse outcome if you get inflammatory bowel disease. So I think if the patient needs steroids, in my practice now, even in COVID, I still use it, but I cut it out paper when we don't need it.
Yes, I would only qualify that, Sue, in saying that, of course, as you've indicated, in the database, there's reporting bias, and the people who are most likely to be reported, those who come to the attention of IBD specialists, and they are the ones who will be come into hospital and be on the higher steroid dose. So I think that there is a signal, and we've seen signals elsewhere for using steroids, and I agree with you, caution and common sense has get them down. But I think how we interpret the secure IBD information is going to be is going to take quite a lot of thought to get that balance right.
Yeah, but your message would obviously be that prefer budesonide over prednisolone.
Yes. Well, so I have as a step towards. Use it first before.
So Ramesh, I had one quick question. Can you hear me?
Yeah.
Okay. Simon, it's been almost more than 4 months into the epidemic. Do you see that the are the relapses less, or are you seeing them as frequently as they were pre-COVID?
Yeah. So Shobna, I've not seen, and nice to see her, I've not seen any change in the pattern of relapse. I've seen, then this is anecdotal experience because it's quite difficult to quantify. I've seen people put up with symptoms for longer and because they've been reluctant to come to hospital, but there's no increase in the risk of relapse unless they stop taking treatment. And that's why it's so important about adherence, optimizing the mesalazine dose, emphasizing the importance to adherence, reducing the risk of having a relapse which needs immunosuppression treatment.
No, so the reason I asked this question is twofold.
Ida, any comments? Carry on.
So I'll tell you why I asked this question. One is that during the COVID times, many people are extremely stressed. So I thought that the risk of relapse might be higher. But when I listened to Sue's talk, she talked about diet. And on a lighter note, because all the restaurants are closed, we are not getting those ready-made deep fried foods. So I thought I might see less, but I'm not seeing any less.
So maybe the home cooked food is not sufficiently healthy.
I have to make a comment.
Yeah.
That I wanted to, I joked about this because I have 2 of my Crohn's patients who are currently in prison for, I won't tell you what their charges are, but they look very, very well when they come to visit. Actually, they look a lot better than before. And I have to say, Sue, that just like, well, maybe a lot of people in the past, we didn't push diet so much, but it's completely anecdotal, but maybe there is something to be said about just having a very bland, they just have fish, rice, and vegetables, as opposed to all these additives and fast food that we're taking.
So in Hong Kong, as you can imagine, most people go for fast food, and there are lots of food additives and highly processed food. And right now, I haven't documented whether sort of relapses less or nothing, but patients themselves has actually told me a change in their sort of control. Again, anecdotal in that sense.
I think I'd just like to put in a word before we take Usha. So there are two things. One is regarding COVID-19. I think I have more than 15, today I had one, so 16 patients of IBD on COVID medications, on COVID infection. So what I realized was 7 out of them were on biologics, and these had comorbidities. A few of them had comorbidities as well, and I thought that they behaved rather well. So we had 2 patients who had significant comorbidities, including IBD, together with COVID, and they did well. So the message is that perhaps people who are on biologics do not have a poor prognosis when treated for COVID and IBD. I think there is some link over there with the patients that I'm seeing. Fortunately, overall, all these patients are doing well and have been mild to moderate disease. Usha wanted to ask a question.
One is my experience has been with our IBD patients that they are going more into remission. They're eating more of home food. There is no travel. And though the stress related to COVID is high, but their in general life stress has gone down because they're not traveling for work, they're not traveling stressed out, sending their kids to school or other things. So in general, I think the life has become slower paced, which has affected the way the body is now getting time to heal. And many patients are actually telling, I'm in remission, can I go down on my mesalamine? I have not decreased their mesalamine. Actually, I think overall they have been doing well because of lockdown and other issues.
Yeah, can I make a comment?
Yeah.
I have a lot of reservation on the current COVID data we are learning. The reason is most of the studies that we are talking about are really observational, retrospective, and not typically designed studies to answer a question. So a lot of these issues that we are talking about, I believe that steroid would be bad and maybe even azathioprine would be bad, biologics would be better, are not based on the way we interpret data, based on randomized, controlled, prospective trial. So we have our own opinion. Yes, these are good. In the situation when you don't have any scientific observation, you have to believe and try to do the best for your patient based on your belief, but still we need more answer. Look at the trial. I don't know what has happened to the journal. Very small data, uncontrolled, retrospective, went to Nature, Science and whatnot. And if you look at those data, like I saw the Proceeding of National Academy of Science USA paper, 10 patient, convalescent plasma, no control. And from that we are concluding, so maybe we are learning, we need time to learn.
Okay. A question to Dr. Matthew Philip. Philip, you did mention about focus shifting back to 5 essays, more optimal treatment or use of 5 essays. What is your comment? Do you see a focus shifting back to 5 essays for broader use in patients with ulcerative colitis?
This question to me?
Yeah.
Is that a question? Matthew, you go ahead.
See, I'll come back to Simon Travis because he already told that. But I think, 5-ASA is a very safe drug. And in ulcerative colitis, time and again it has proven to be very good. I still use 5-ASA very, very commonly probably is my first drug for ulcerative colitis. There is no doubt regarding that. And as he's told that he is not using 5-ASA for Crohn's disease, but for Crohn's disease also I still use, especially for colon-specific Crohn's disease, and I use, it is found to be useful, particularly those slow release 5-ASA preparations. But it is not my favorite drug for Crohn's disease, but for ulcerative colitis, yes.
Professor Simon, also your comment on Dr. Sue's point of, she did mention that we should be thinking of using mesalamine to induce remission in mild to moderate ulcerative colitis. Am I right?
I'm a great advocate. I share Matthew's enthusiasm for 5-ASA. It's a good drug, but it doesn't work in the packet. Patients have got to use it. It's got to be the appropriate dose, and that meta-analysis and systematic review published in Lancet Gastro from a couple of years ago encourages higher dose, and the topical use of 5-ASA, in addition, whether it's suppositories for rectal disease or enemas for more extensive disease, it's good for inducing remission. More than 2/3 of people will go into remission, let alone a higher proportion with response. So go for it. And if you want to avoid immunomodulators, then the combination oral and topical 5-ASA is a good way of maintaining remission, avoiding immunomodulators in those patients who will take it. Commonest reason for 5-ASA not working is because the patient isn't taking it.
Yes.
Thank you, Simon. I actually have a question from the floor, actually, from the audience. So patients with inadequate response to optimized 5-ASA require escalation of therapy to oral prednisolone in ulcerative colitis. But in case of escalating to oral prednisolone, do we stop the 5-ASA? I think that's an interesting question.
I think everybody continues it. I would certainly continue it, and I would only reference previous discussion. I would go from 5-ASA through budesonide to prednisolone, but I would certainly continue 5-ASA throughout. Is that your practice, Ida?
Yes, it is, except that I think we do know that there is this so-called paradoxical flare and things like that, and some people they said that you don't have to actually give mesalazine at the same time, or 5-ASA at the same time as steroids. I mean, I continue it, just it's convenient because usually, you know, you would continue that as maintenance therapy anyway. But yes, I suppose.
I agree. There's little evidence there's any additive effect, but it's like a passacaglia, to use a musical analogy. You need the theme of continuing your maintenance therapy, even if you bring in the kettle drums of the steroids to bring things into remission.
I think in India also probably it's a practice to continue with 5-ASA. Devendra Desai, you could correct me if I'm wrong. Most of us would probably continue with 5-ASA. Even when the patient is on steroids. How is it in Bangladesh, Professor Dr. Masudur Rahman?
Yeah, you're right. The practice is similar here also. Most of us also continue the 5-ASA.
Okay. Now we go on to the second talk.
Yeah.
Of course, we've already had.
Dr. Ramesh, before we go for that, there's actually a flow of questions coming. So I'll just quickly go on to one or two. So Professor Eli Ogutu from Kenya, he wants to know that if a patient is ulcerative colitis is in remission, for the low resource countries, are you going to stop 5-ASA?
Yes.
And the second part of the question is that if the patient, we are starting steroids, should we stop the 5-ASA? These are from Kenya. So this is.
I think the first question was answered, Rupa, which is that to continue the 5-ASA. But yeah, would you consider stopping 5-ASAs in those on remission, I think is the question. Does anyone take that, Sue or Simon?
No, I'm happy to take that. I would continue. The only caveat I would say for people who are struggling to pay their medical bills is that you don't need to go for the most expensive 5-ASA. You just, I think that good old-fashioned sulfasalazine, tolerated by 80% of the
No.
people, I would advocate, but I'm prepared to be a voice down. Sure, but most people could tolerate it, and better they take something they can tolerate than, to my mind, that rather than not take anything at all.
Yeah, the companies will never invite you again. I'm just kidding. Yeah, actually, yes, it's true. I also use sulfasalazine for those who can't afford it.
I think there's one scenario, and that is the study from Mount Sinai showing that you will stop 5-ASA in patients who are on biologics, because they show that by stopping, because a lot of times you escalate patients to different treatment, but you still keep them on the original treatment. Of course, if you want it for chemo prevention, fair enough, but if not for that reason, it shows that when you stop the 5-ASA, it doesn't cause a worse adverse outcome. But if someone is just on 5-ASA and they've been in remission for a long time, this is a study we are doing with Rupa and Ida, and that is if someone is on remission for a long time, can you sort of stop that? So hopefully in sort of a year's time, we can have some results. So these are people who've been in remission for 2 to 3 years. Then we can think about whether because of cause or other issues they can stop it. And the answer is we don't really know, at least for now, the relapse rate. I mean, in a withdrawal trial setting.
Sue, I think, in patients who is on remission means, is it a clinical remission or a histological remission?
For our study, we use clinical remission, and we also use biochemical remission based on fecal calprotectin level, not to the extent of histological remission. Although I know that's one of the treat to target issues with ulcerative colitis.
Thank you very much. I think that's right. I actually wanted to ask Dr. Ajit Sood. I know that you published a paper on nutrition. I think nutrition, is the big thing now. What would you say, because patients will ask you all the time, actually they've been asking me for a long time, and I don't think we've been giving them very good advice. What would you say, other than this, enteral nutrition, would be the diet that you would recommend? Like really, rice, no rice, just things like that. What would you sort of advise your patients?
Regarding nutrition paper, we had 6 patients who had very severe Crohn's, and 3 of them were in fact failure to biologics, and we didn't have many choices. So we opted for, we advised them about the EN, and we were really surprised that all of them did so well. The problem in India is that the EN cost is very high. It comes to nearly 2,000 rupees a day, which means around $40 a day, 40 or 45 or $50 a day. So it's difficult. But most of the patients, when they're sick, they tolerate for 8 to 12 weeks. And what we are pursuing is that these patients, we have put them on now PEN. We're trying to see the long-term response, that how do they maintain the remission once they're added PEN. We are working on diet, and we have a diet plan for patients with the IBD. And we are working on diet in UC also to some extent. But as such, if you ask me, is there a specific diet at the moment, I think nobody really knows what is a specific diet. But what we want is that there should not be many deviations in the diet. Like whatever is our habitual diet, if we can still stick on to our habitual diet, that I think our body is quite used to our habitual diet. In my mind, the problems happen when there are too many sudden deviations from the diet. That may be more harmful, that may impact microflora to a greater extent than any particular kind of diet.
Usha wanted to make it, yeah.
Yeah. Okay, so we're talking about optimizing therapy, and what about therapeutic drug monitoring? Is that a big thing in India at the moment?
Maybe Dr. Desai can help on this. Dr. Desai.
Could you unmute yourself, Dr. Desai?
Yeah, sorry.
Yeah.
Could you repeat your question, madam?
What is the role of drug monitoring in the Indian scenario? Since we are discussing low resource countries, do you think that immunomodulators and...
So basically the experience that happened to us and we have published, that we also come across the similar patients who fail for thiopurines as well as biologics. So in these patients, since we have limited availability of biologic, we have found that it was very important that the role of therapeutic drug monitoring, and we have found that it is very useful, similar to what is the experience in the West.
Okay.
Is it, but is it expensive? Because
Yes,
installation
it is
very
expensive, but compare the cost of biological and the cost saving which is attributed to therapeutic drug monitoring, especially for biologic, it becomes much cost effective. Can I just ask one question if I am allowed?
Sure.
I actually read Hughes' paper in JGH that there has been no case in Hong Kong and one other region about COVID. So what is the secret? You know, not a single case, like we are already discussing in India about 54 cases.
I don't think I can't claim credit for that. I don't think I can. Thank you, Dr. Desai. You're absolutely right. So together with, in fact, it's not only Hong Kong, it's also with Taiwan. So with Xu Cheng-Wing from Taiwan, we look at our whole population-based thing, and we, well, touch wood, up to date is still sort of zero COVID in IBD. And I think it's also partly the psychology, and it's all back to the mentality, because Hong Kong was hit by SARS in 2003. So people immediately mask up, hygiene, they are completely, tuned into the 2003 SARS when it first came about. So and for your information, actually we have not been doing telemedicine. Our patients do come to clinic actually, so we still continue the biological process. So it's all probably the whole structure in terms of shielding and getting people in there. But hopefully it will stay like this.
It is almost 15 days or a month, but not a single case. Any afterwards?
Yes, no, not yeah. So we also tested actually in the population-based setting, and we found that we found that they were all negative. So we did a small cohort of population testing, because the mild ones, some may argue that you don't know, they might have had it, but they don't come to hospital. But the sort of over 50 cases, they were negative in the IBD cases.
Dr. Usha.
Yeah, I wanted to make one comment about micronutrients. You asked about nutrition. Two micronutrients which will benefit in IBD as well as COVID is vitamin D as well as zinc. These two drugs have been shown to be beneficial in prevention of COVID infection, because it helps in the trafficking of the ACE receptors and all those things. Secondly, in IBD, we have shown that vitamin D reduces the disease activity, especially if you keep the serum vitamin D at about 40 nanograms per deciliter. So, addition of vitamin D in these patients with zinc may be a beneficial thing for COVID and IBD.
Okay. Dr. Matthew Philip, you wanted to make a comment. Dr. Rupa, are there any other pressing questions?
I was actually going to ask Govind a question actually, and it's fitting, Govind. The gluten question, because a lot of my patients ask me that as well. And what's your opinion about gluten-free diet and inflammatory bowel disease?
The gluten-free diet in IBD.
Yes.
Okay, so there are some observations that because especially in US and Australia, people are using gluten-free diet for general health, and they do report that their IBD gets better. But there are no structured study on this regards, and the symptom improvement with gluten-free diet in IBD is based upon a couple of things, that they also have low FODMAP. Because once you stop gluten, the amount of FODMAP also decreases, and therefore the symptoms of diarrhea or blotting sensation, they come down. So there's no cause and effect relationship at this point of time, but this is an interesting observation. Secondly,
and it might be the FODMAP sort of thing, is it, you think, or is it gluten per se?
No, even it could be gluten, because now there are data that many patients with IBD can also have a celiac disease, which is not diagnosed. And the big study published a couple of months back, and there are multiple other small studies that patients with IBD can also have associated celiac disease, and vice versa. The many celiac do have. We have a patient with celiac disease who have a IBD.
I think there is one question which many have actually asked, and I'll leave it to the panel. Maybe from Bangladesh, Professor Farooq, Professor Masudur. The thing is that there are a lot of people asking what is the role of probiotics in IBD. We're talking of diet, nutrition. So maybe Sue can give a comment first, followed by Dr. Masudur or Farooq.
So for probiotics, if you look at the clinical trials, the evidence has been, the efficacy has been in the cases of pouchitis, chronic pouchitis for induction and maintenance. But in terms of Crohn's disease, I'm not aware of any sort of evidence. And in ulcerative colitis, there was some early study of using BSL-3, but it's very controversial. And I don't think, at least now, we haven't really seen one or any that sort of stands out that actually can, in terms of the hard endpoints of what we use in the clinical trial setting of induction and maintenance of conditioning.
So this is from Dr. Tan Tan from Myanmar. I suppose you've got your answer, but from Bangladesh, we actually have recently got a lot of papers on microbiome and growth retardation, and they've made it to the NEJM. Comments from Dr. Masood.
Thank you, Rupa. In fact, I have nothing to add with Sue. It's only effective in bowel site is Crohn's disease, but other data does not support its definite role in either ulcerative colitis or other forms of the Crohn's disease. So, if I am allowed, may I ask a question to Simon?
Yes, please. Sure. Yes, please.
Yes, Simon. Patients with steroid-dependent ulcerative colitis who has the frequent relapse after varying the dose of the steroid, should we add at this pandemic stage a immunosuppressive? I mean the azathioprine or 6-market to purine. We know that in our resource-constant area, very frequently we cannot add the biologics. Should we add the 6-market purine or azathioprine? Or should we stay on the steroid with the hope that this will be over very soon?
The conventional approach, of course, is to start immunomodulators and the thiopurine, be that azathioprine or mercaptopurine. But one needs to be a little bit innovative in thinking about how to get round that if it can possibly be avoided. Now, it's well understood that biologics, which might be a way around that, are highly expensive and the sustainability is difficult. But there are other approaches. And I mentioned the optimizing oral and topical 5-ASA. That's one. It's underused, that actually, for avoiding the immunosuppressants. But at the end of the day, it's what is the risk, the least risk for the patient. And steroids, continuing steroids, is a high-risk strategy because of its systemic effects, stand aside any impact of the pandemic. And if the way of getting somebody off steroids is to use azathioprine, well, so be it. You have that discussion with the patient, and you talk that through, because others will also say, well, what about the place of surgery? I had an Indian patient this morning come and who specifically wanted to talk through about the role of surgery for his colitis, even though there are a range of other medical options. And I think that you need to have that open discussion with the patient. I'm not advocating that, but for some patients, they may say, well, that is seen as as the option they would prefer. So I'm not saying don't ever use thiopurines just because we're in the middle of a coronavirus, but I think if you can find an innovative way around that, then we just need to think outside the box.
Do you see a bigger role for methotrexate?
Not for ulcerative colitis, actually. I think that methotrexate for ulcerative colitis has had its day. For Crohn's disease, certainly. But is methotrexate any safer than azathioprine? Well, possibly, but we get fewer reports because it's less used. But at least there's good randomized control evidence for Crohn's disease for methotrexate in Crohn's disease. That can no longer be said for ulcerative colitis. I think it's had its day.
Okay, I think.
Can I ask a question? Parveez?
Yes.
What happened is we use azathioprine a lot, but I am asking opinion from Simon that sometimes the young ladies, they're worried about having azathioprine during pregnancy. But the moment they try to actually stop it, obviously they are going to have relapse. So what is your opinion on continuing azathioprine during pregnancy?
Uday, I would say that that azathioprine is safe in pregnancy and in breastfeeding. Same goes for mercaptan. There have been lots of concerns around it, but I absolutely proactively discuss that with young women because it's so important. The GPs and the obstetricians will do some shroud waving, but actually there's a huge amount now of published experience, and internationally I think we accept that it is safe in pregnancy. No detectable amounts in neonates who are breastfed. So I would say continue it because they do not want a relapse during pregnancy. However, just touching briefly back on the question of do you need to continue 5-SA during azathioprine, well, there's the Italian study from Sandro Ardezzoni suggests that the only people who maintained remission on azathioprine without relapse were those who are taking 5-SA. But I think many people say if you're going to take one drug and you're needing a thiopurine, take the thiopurine and worry less about the 5-SA. We tend to continue both, but that's out of habit.
Ramesh?
Yes.
Thank you very much. I think we're probably gonna, Rupa, do we have more time, or I think we may have to wrap up soon? I think there's so many questions.
Yeah, so there's a deluge of questions coming, but I think we'll wrap up after a quick comment by Dr. Shobna.
Rupa, I think the discussion has been very useful. Personally, I tell my patients to eat whatever they can handle. Milk, if they can handle it, fine. If they can't handle it, stop it. Wheat, let them have it, because most people in northern parts of India will not have a pure rice diet. They won't like it. So if they have it and they can manage it, fine. But I tell them to avoid refined flour.
Yeah, I think diet is the next big thing for IBD, and I think diet, microbiome, IBD therapies based on diet is what, as a part of this platform, I think that should be our next aim, and I'm sure if we are together, we'll be able to do it. I'm really overwhelmed with the number of questions that are coming. It was really not possible to discuss all, though we actually crossed time. We are half an hour more into the panel discussion. So I
have to leave now, Rupa, because I have another meeting. I think I messaged you.
So I thank everyone.
Simon.
First of all, I thank Dr. G.N. Ramesh, Dr. Ida, of course, dear Ida. I thank Simon so much. He's been a mentor, a support and a guide. I thank Dr. Sood, Dr. Govind. I thank Masudur, Professor Farooq, Dr. Shobna, Dr. Usha, Dr. Devendra Desai, Dr. Uday Ghoshal, Dr. Matthew Phillip, Sue, of course, everyone, thank you so much for making this a success. We've had an overwhelming response. All this would not have been possible other than Dr. Azad Mupen. He
Thank you
is a
so
person
much.
I want to highlight once again and thank him once again because of what he has done, his constant support for the movement called IBD and movement of IBD in this part of the world. So
And
thank
we
you
thank
everybody. I take this opportunity. Could I have the slide please? I take this opportunity to first thank our exclusive scientific partner Janssen Immunology, J&J for their support, and our other academic partners Radiant Pharmaceuticals Bangladesh, Mega Myanmar, Sun Pharma, Dr. Reddy's, Zydus, Microlabs, Ferring for all their help in making this successful. I am sure together we can manage IBD in this part of the world and ultimately be of benefit to all these young patients suffering from a chronic lifelong disease. Thank you once again.
Thank you. Everybody, thank you so much.